Thanks very much. So we're here today to talk about Moving Medicine. Moving Medicine is a free online resource for healthcare professionals, which supports them to have conversations with people living with long-term conditions about being more physically active. And we're going to talk about how this is happening in Birmingham. There are different components to Moving Medicine. We have our prescribing movement resources. We have 21 adult resources, 6 children and 6 young people resources, and they're built around this motivational interviewing framework. We have Active Conversations online course, which is our paid for course which teaches motivational interviewing in the context of physical activity. Within our Active Hospitals work we've done, we have an Active Hospital toolkit, which has case studies, governance, information, business cases to support healthcare professionals to embed physical activity into secondary care. And we have clinical resources to back this up. Within sort of our getting involved section, we have campaign resources such as the I Can, which you can put up behind a bed in a hospital, and it helps support healthcare professionals to see and get people moving if they are an inpatient. We are also looking at developing forums and building a community of practice for different areas, and more information on this will be available shortly. And we are running a pilot within Birmingham on physical activity clinical champions. As part of the physical activity clinical champions programme, we're going to do a place-based approach, which will enable us to come and give presentations within the various trusts and GP surgeries. We also have Moving Medicine Birmingham. So we have the main Moving Medicine resources, but at a local level, we have Moving Medicine Birmingham, which highlights just at a place-based approach and has this microsite, which is accessible. So we have Moving Birmingham. So it has a look and feel of Birmingham. We have background images of Birmingham within the video. We also have quotes from people within Birmingham. So we've got Dr. Justin Varney on the website. And we also have signposting to support and local activities. So it's relevant and useful for people and healthcare professionals to use within Birmingham. And now I'm going to pass over to Dr. Faisal Shaikh.
Thank you, Lacey. So presumably you can see the screen again. Yep. Yeah. Right. Hello, everyone. My name is Faisal. I'm one of the sports and exercise medicine trainees here in Oxford. I'm also a GP based in London and a GP with a specialist interest in musculoskeletal medicine in Surrey. And this is a project we did on addressing health inequalities by making our healthcare translations more relevant. Now, I've got 49 slides and 15 minutes to go over them. So I'm not going to subject you to all the 49 slides. So don't worry, I'll wrap this up really quickly. But essentially what we will be looking to do is to understand the challenge of healthcare translations, look at some of the solutions, and then try and look to see how we can make some of these solutions better. I prepared a Slido conversation for anyone who's interested in getting online. So if you can just get onto slido.com and to put in hashtag moving medicine, or just scan the QR code, and there will be a few questions along the way. I'll leave the slide on for a quick second. Just go onto slido.com, put in moving medicine, and then or scan the QR code. So I'm just gonna move on now. So the first one I just want to do is get a little bit of an idea of what your professional role in clinical setting is. You might prefer to just put this in the chat box, and Eloise can let us know a little bit about who you are and what you're doing. I'll move on from this slide very quickly. So we know that there's at least one doctor and somebody from public health, which is good. Sorry. On there, but I'll leave this GP trainee. That's great. So it sounds like there's a clinician-heavy audience, which is good. So I'm just going to move on from this, and we can go on to the next question. Now, here's the other question that I was really interested in. How often do you share patient-facing material with patients? Now, this could be a leaflet or a website link or some kind of video or webinar like one of these. It could be anything that you would want to share out to patients. And just pop in on the questionnaire. How often do you do that? So I got one respondent who definitely does this several times a week. Some people do it once or twice a month. It'd be really interesting to see if there's anybody who can't remember the last time they shared something to patients. I'm hoping that there is no one here who, and there's no one here who does that. So the point being behind this quiz is to get us to understand that the patient-facing material, whatever you share out to patients, is a big part of the consultation itself. If you see a patient, quite often you would want to share something out, and this is the focus of the talk today. So understanding the challenge, the multiculturality, intersectionality is on the rise. We know that you cannot go through a medical career or a professional career facing patients without coming across patients who perhaps don't speak English. Certainly in Birmingham, 15% residents do not speak English as of their main language, and this is from the ONS statistics from 2021. Nearly a third of people in Birmingham do not speak English well or at all. And according to the 2011 census, some of the most prevalent languages in Birmingham were Urdu, Punjabi, Bengali, and Somali. And this is changing, the landscape changing a little bit. Romanian and Polish languages are on the rise, but this is just the data that we have from 2011. So I want you to think about the last time you dealt with a patient whose language you couldn't speak, or perhaps a culture or their religion or their background you were very unfamiliar with. And those of you who've dealt with these types of patients, you would remember that it's a difficult experience, isn't it? On the one side, you know that this consultation is going to take time. You know you're going to have to do some kind of three-way consultation with an interpreter and a patient, and perhaps even the family involved. And then you can only pray for a good interpreter. And family is a mixed blessing. On the other hand, you know that patients who have cultural and language barriers tend to have poorer health outcomes. You also know that the greater the distance, so we have this evidence from psychiatry, the greater the cultural difference between the clinician and the patient, the poorer the outcomes in the patient, simply because of the widening of the language barrier. And only about 10% of people 10% of patients tend to remember about 10 to 15% of what's being said in the consultation. And that's for patients who speak your language, who are from the same culture, some from the same background. We don't have any evidence on how much recall exists in patients from different languages and different cultures. So, have you ever tried giving them patient-facing material? I mean, my personal experience is a mixture of uncertainty and frustration and dissatisfaction as I see the standards of care go down. And sometimes it's just like this. It's like, I have no idea what you mean. I have no idea what's happening in this consultation. No idea what's going on. So this is the next question. Does your experience correlate with my experience? Do you also have similar experience particularly when you try to share patient-facing material? Because the consultation has been tricky, and you often find that there isn't enough to give them in terms of patient-facing material that might be relevant to them. So there's not much experience, not very good. Ignore this first one. That's just me testing the Slido app, and we're waiting for one more response. Yep. So it looks like not much experience, and somebody said it's hard to find. So that's the reality, isn't it? I mean, there are plenty of experiences, plenty of stories that I've heard from clinicians and my own personal ones, where it's just very hard to find information that appeals to patients in their language. Now, so what's being done about this? The state of healthcare translation is such that often healthcare translation is an afterthought rather than a proactively planned part of the service. And language and cultural barriers are not well understood. There are no clear standards for translation quality, and there's little research attention that's been given academically to this topic. To give you a simple example, I did a search on healthcare translation quality. I hit 217 results. This was about a few months ago now, it's about 6 months ago. I hit 217 results, and almost all of them were about clinical translation, about research translation. And that's evidenced by the first hit here, which talks about pharmaceuticals and adverse events in weight loss, nothing to do with healthcare or with translation. And this is a common pattern when you do research, when you try to look up this topic or aspects related to it. And generally, in my experience, there's two types of healthcare providers. There are those with an established strategic, political, or legal motive. So think about OHID or the World Health Organization, large organizations which have an established legal or political motive. Pharmaceutical industries. I put them all in tier one, and then everybody else who organizations like hospitals, GP practices, ICSs, ICBs, all of these will perceive a primarily clinical need, and I put them down in tier two. And the reason is because the way they approach translation is quite different. So tier one services will typically outsource their translation needs completely. They tend to have very rigid protocols and have very little cultural awareness, and often use this strategy called translation back translation, which is where you translate into the target language, and in order to know whether your translation is good, you translate back into English or your native language to find out whether the translation is good. And as much as it's a good system, it's got its problems, and we'll talk about that as well if we have some time. Overall, there is little control of over the outcome of the translation. But tier two services, GP practices, hospitals, etc., usually translations are insourced. So usually it's put down onto bilingual staff or friends and family of staff. Oh, it's more a case of, oh yeah, I know this nurse who speaks this language. Maybe she can help, and then she's sort of brought on. And then, next thing you know, she's doing the translation for us. Generally, there's an absence of translation protocol. There's very little quality control. So there's a lot of variation. Sometimes you get really good sort of translations. Other times you don't really get that, you don't really get a good result. And again, there is very little control of the outcomes. We don't really, the organizing bodies, the managers or the authorities don't have much control over the outcome. Partly because you don't actually understand the language that you are translating into. So it's a big problem. So here's a quick question, 15 seconds. What's the most important component of the translation process? You only have 15 seconds to do this one. I'm not sure why I put a timer on this. Probably shouldn't have done that. But just pick one instinctively. Okay. Not sure if someone's managed to read the question and actually answer in that time, but we'll just move on. Because there is an answer, but I'm not sure if yep, no one's participated. It's too quick. Next time I'll make sure to give you a bit more time on this. So the answer to this is not translation accuracy, it's cultural competence. It's, I think somebody mentioned that already, pointed that out. But what does cultural competence actually mean? And let me see if I can give you some simple examples using internet forwards on translation fails, as they're called. It might give you a bit of an idea of what sort of things we sort of up against, what sort of things we're dealing with. Now, just a quick warning before I do that, these are translation fails they picked up from the internet. They're meant to demonstrate the complex nature of translation. They're not intended to target a particular group or to offend anyone. If offense happens, it's not intended at all. And please point it out directly to me, send me an email, and I will address it personally. It's just to sort of point that out, that this is in the interest of education and development. Now, I've got quite a few examples, but I'm not going to go through all of them. Perhaps this one is an interesting one. So this is from the original Turkish, and the translation is in English. As you can see, the English says, do not use the problem. Actually, the Turkish says, there is a problem. That's the first line. Do not use. And that's the second line. So what's happened here is that they've made a translation, but because the Turkish language, the words the words are reversed in order, because originally, before it had the Roman script, it had the Persian script, and the Persian script was written from right to left. So the language is written in the Roman script, which is left to right, but the word order is still right to left. So it's common for translators to get the order of the words wrong, and as a result, they turned the sentences around completely, making it look like actually it was there is a problem, or problem, do not use, and they turned it around by saying do not use and problem, and then they connected it with the word the. So technically this is an accurate translation, but the word order has been misplaced. leading to a completely different result. Here's another good one. So good appetite. So this is I think it's a Caribbean restaurant, which has tried to translate the French phrase bon appetit, which has been naturalized into English, and they tried to translate it as good appetite. And technically, the translation might be considered as accurate, but it loses the point of the phrase. The phrase really refers to, enjoy your meal or have a good meal or something like that. And you can see what the translators were trying to do. They were trying to put sort of the word bon appetit in different languages. And they probably wanted to keep that two-word sequence going. But unfortunately, there is no two-word phrase for equivalent to bon appetit in English, and that's why we use the French phrase. But unfortunately, that was lost in there, and it's been translated as good appetite. And again, it's an accurate translation, but it misses the point of the translation. And these are the kind of experiences that you see often. Here's another good example, yet from the Finnish. So this reads, the bit at the top reads, unfortunately, and then the bottom bit reads, elevator is broken. But when they translated it, they changed the tone of the language completely by saying, due to happenstance beyond our control, this elevator is so broken. And when you get this sort of translation, what's really happening is that the tonality of the target language compared to the original language has been changed significantly. So it's technically accurate, but it's just coming out as completely wrong. Another example, for those of you who can read the Urdu and the Arabic, the Urdu at the bottom just reads, this place is for women only, men are not allowed. It's actually quite a simple tone, but the tone becomes quite aggressive in the Arabic, and then in the English, it just becomes very emphatic, and it says, special women just are not allowed to enter the men ever, and the order is completely mixed up, and it's just become a complete and utter disaster. But if you look at it in the original language, it's actually quite a decent low tone. It's quite straightforward. It's quite matter of fact. But unfortunately, an accurate translation has been made without reference to the original, the equivalence, the semantic equivalence. So here's another quick question. I haven't put a timer on this one. Can an inappropriate translation cause harm? The options are absolutely, maybe, never. Patients are sensible to know themselves and know themselves well. So we'll move on from this. So yep, so someone said absolutely, someone said maybe. Absolutely correct. I mean, let me give you an example here. Oops. Let me give you an example here. This is taken from the research database of pharmacies in the US using Google Translate, the equivalent of Google Translate, some translation software to translate pharmacy prescriptions into the Spanish language. And then these examples have been back translated back into the English language to give you an idea of sort of what these translations were like in the Spanish. And you can see over here, some of these sentences make little to no sense at all. And this is what was being given to Spanish-speaking patients in the US, being prescribed by pharmacies. And it's an interesting one because there is the translating software did not understand the difference between the word once, which is ONCE, once in English, which means just one time, versus the Spanish once, which means 11 times. So it was translating take one tablet once a day into take one tablet 11 times a day. And as you can see over here, this is an example of that. It sort of asked them to take medication 11 times a day. And it was just quite sort of terrifying and scary to see sort of some of these results being sent out there. This is so moving medicine, as Lacey quite rightly pointed out, said that we have a large resource of evidence-based material supporting physical activity promotion for clinicians and patients, and motivation is a large part of what we do. And looking at all these examples that you've looked at before, how do you motivate someone to go about it? How do you motivate someone in different language if you can't get them to understand what you're trying to say? And this is the challenge that we took on, and we aim to increase the probability of achieving our desired functions from our patient-facing material. And what really needed doing was to improve the quality of the translation, streamlining our process, designing appropriate evaluation methods, and then using existing infrastructures to make it reproducible. So what we did was we collaborated a lot. We collaborated with the University of Edinburgh, with the British Tamil Medical Association. We used Tamil as a target language for the first time, and the faculty, and we got together clinicians, linguists, bilingual professionals, translators, and patients. And we started doing literature searches similar to the ones that I've sent you, not the translation fields, but there's a big database of literature searches, which I wasn't able to bring in here just yet. We had MDT meetings, we generated and refined ideas, which we reviewed, evaluated them, and then we just sort of did it cyclically until we came up with this massive, scary concept of all the things that we need to be addressing, and then this schematic of translation framework. Now, I don't have the time to go through the entire translation framework, and I think I'll probably put you to death by PowerPoint if I did that. But I am going to bring out one or two learning points that we did. So one of the benefits that we learned from this is intralingual translation. So oftentimes the original leaflet or the original material needs to be simplified so that the translation can become more culturally appropriate. And here's a good example of that. So this one, as you can see, originally it said improved glycemic control. We changed it to controls sugars better. So it's just a way of demonstrating how you can simplify the language in the original, just so you can get a better translation of the original. The other thing that we identified is that healthcare communication usually has three major functions. One is instruction, so like the pharmacy prescription. The other is education, where you're just imparting knowledge. And the third one is motivation. And what we realize is that for the instructional side of the translation process, you need to be very specific. But for the education and the motivation, you can be a little bit more vague. And this is the reason why Google Translate will almost certainly never work in a pharmacy prescription, but does have some potential when you're using it in a clinical consultation. So it's a case of what parts of the consultation you're using Google Translate for, and what information is being transmitted, where you can actually so if you know this, you can utilize online translation services safely and hopefully effectively. The other thing we also designed is this concept of a translation team. So typically translations are done by one translator or two translators working in tandem. What we did was we designed a team of 3 people. One of them was a translator. The other was a mediator, which is a bilingual clinician who has some idea of the target language, but also has some idea of the medicine or the original leaflet. And then we have a subject matter expert, which is a person who may not know the target language at all, but he knows the subject of the patient-facing material really well. And we found that if you were to combine the 3 and utilize our framework, and there's some pictures of that framework here, you're able to get a better response, of overall better control of the translation process. And what we did was we used the focus groups to score the translations using an established score sheet, so that we could come up with some kind of standardized process to know whether the one translation was better than the other translation. And that's what we did. And you can see here that the MDT translation generally scores better for most things. So that's what we're doing now. What we're looking to do next, this is probably the more exciting bit, and bit that you might be able to cooperate with us on. We're looking to get translation workshops, so we can condense this process into a shorter period of time, maybe a sort of 1 or 2 sessions, 1 full day, for example. And then we're looking to develop bilingual clinician education. So we have in the NHS a big resource of clinicians who are bilingual or even multilingual, people who speak many different languages, have access to different cultures, and they can be really useful if we are able to bring some skill and translation competence and cultural competence into them. And we're working on a little curriculum for that. And then there is obviously the actual production of culturally appropriate patient-facing material and its deployment in different healthcare delivery centers and public health bodies. So together we can, you might wonder what if you're interested in this, what might you be able to do? Well, together we can create awareness and collaborate. We can talk about the difficulties and the challenges of healthcare translation. We can refine and develop translation protocols which are relevant to your organization, to your population, to your people. So GP practices in Birmingham are different from hospitals in Birmingham, for example, and are different from hospitals in London or Oxford. So understanding the local needs and then developing a translation protocol, just putting a little bit of effort into it, upskilling our bilingual clinicians, appealing and lobbying for funding, for opportunities, just the general awareness of recognizing that translation quality needs to be improved. It's a long time coming, and it needs, and it would help the outcome of our patients significantly. And yeah, that's basically me. So in summary, this is a challenging area, but much is needed. The aim is to make translations more relevant to our patients. Our efforts are very much a work in progress. There's many things you may have seen in the presentation which you perhaps didn't agree with, etc. But there is some promise in what we're doing. We're looking to collaborate. So if you're interested, just send me an email on this email and we can work something out. Thank you very much.
Hi there, everyone. My name's Sam. I'm one of the Sports and Exercise Medicine registrars in Oxford, also with Faisal, and I've been working with moving medicine for several years. And I'm going to talk to you a little bit about how we've been promoting physical activity in a specific hard-to-reach community, which is really relevant to Black History Month, and also give some ideas about how you might be able to do this in your own communities alongside this as well. So our focus was on health inequalities. We looked at the data that was produced by Public Health England in this document I've put up there, Understanding and Addressing Inequalities in Physical Activity. And we found that only white, British and Chinese ethnic minorities had increased activity levels between 2015 and 2019. And inactivity was much higher in Black and Asian communities. To delve in a little bit deeper about what that actually meant, we could see that not only was inactivity higher in Black communities and in Asian communities, but the levels of activity were also lower as well. So although 62% is quoted as the percentage of adults that currently meet the physical activity guidance, that's only 55% in Black communities and Asian communities. So almost 10% lower. So why is this? I mean, this is quite a complicated diagram of the challenges and barriers to physical activity, but it really shows the different organizational, individual and community aspects that can interplay to cause physical activity to be less in these communities. And it's a really complex system of criteria to do, not only with the knowledge of physical activity and the health benefits, but also with the ability to do physical activity because of cost. And availability of open spaces and safety. So there's a really complex interplay to why people are not able to do physical activity in these communities. So 3 major themes were identified, which was enables barriers in identifying opportunities, but also community consultation and engagement, and a holistic approach for protected characteristics and intersectionality. Now, what are we trying to get to? And I always like putting this diagram up because it really shows where we'd like to be. And obviously liberation is where we would really like to be in the bottom right there. That's an example of removing all the barriers, removing all the challenges so everyone can have equal access and equal outcome of opportunity as well. So not just giving everyone the same amount of stuff. And I think currently what happens is, across the board, services are spread out amongst all communities evenly, and we get what we think is equality, but those people that have issues and difficulties in accessing need more, and I think what we need to be able to do at the moment is get to some level of equity where we actually reach the communities and do the things in the harder to reach communities that might benefit them, so that we're getting some equality of outcome before we get towards liberation. Now, why is that important? Because Black, Asian and minority ethnic groups, or ethnic minority groups in general, are actually concentrated in some specific areas. So that's Manchester, Birmingham and London. And over 50% of the entire nation's minority ethnic groups live in these 3 cities. So if we're to try and address the inequalities of physical activity, we need to address it in these regions. And Birmingham specifically, you can see actually in some areas of Birmingham, you know, there's greater than 80% ethnic minority concentration of people. So these are the areas we need to be addressing if we're to be able to address the physical activity inequalities. And there's a long list of recommendations that came from this book, which really were interesting, because it included things about going beyond the individual-centered approach and addressing community levels, and also acting as an enabler for participation with group-based physical activities, and also combining interventions with healthy lifestyle, so cross-cultural needs, and also health education as well. Now, we put all this together, but you know, this was just a long list and didn't really help us try and figure out how we're going to address these specific communities. So we looked at the enablers for physical activity. These were things like social belonging, friendship, sense of achievement and success, feeling that their specific needs were understood in those local communities, and also feeling represented in planning and delivery, you know, empowering people to be able to do physical activity in their own communities by making more accessible facilities. So what were our aims? Create an open forum, develop a local partnership, understand individual needs of the community, and be able to address these environmental and social factors that were causing them to be physically inactive, and maybe even get some funding and development for projects. Creating a safe environment and locations which was free from discrimination, but really it was targeted interventions to optimize engagement in physical activity. So how do we do this? So I'm proud to say we created a group called Horizon Youth and Community Action Group in league with Harrow Council, who gave some of the funding for this. And the concept was to improve the health and well-being of Black and ethnic minorities in that community in Harrow. It's where I grew up, so it was easier to do. And there are several groups that we've been involved in before that could come together to create a specific health-orientated group. And my role was purely physical activity, but the actual group itself has been able to expand and create more about the wider determinants of health in the Black community in Harrow. How did this actually work? So this is an example of one of the talks we gave. I gave a talk on physical activities and healthy lifestyle, which was followed by a gym workout and health walk last year. And you can see here, it was you know, several people getting involved in the health walk and the free gym sessions that we're able to put on, but also the engagement from different people who normally wouldn't have access to this sort of information or healthcare. And, you know, wide-ranging questions came from this talk about physical activity, some really surprising questions as well, which you would never know to address if someone had asked you, because we all know all the different reasons that physical activity is important, but a lot of people don't have that information, and delivering it at source was really important. Another talk we gave just last week was about my focus on type 2 diabetes and how you can address type 2 diabetes with physical activity. But we also managed to get other GPs involved to give talks, and nurses to come in, specialized nurses to do blood pressure checks, give advice on hypertension, give advice on type 2 diabetes as well. And it really, now it's kind of approaching all the things that affect the specific community, and again we were able to do a health walk after this. And now the group has expanded and is able to do a lot of physical activity projects. So they do a weekly social hub where people can come and use the gym for free if you're part of the group. They do weekly health walks where the community can become engaged in keeping fit through walking or through outdoor gym activities as well. And they also do talks where they get together and have discussions amongst themselves about different health problems they may have and how they might be able to address it themselves. Sometimes they're attended by health professionals as well, who might be able to give them answers to some of these questions at source. And we've got a lot of people who are scared of visiting a healthcare practitioner. They're scared of going to their GP. You know, there's immigration issues associated as well. There's a fear of healthcare, fear of government, and having these community groups really delves into how we can approach and reduce that healthcare inequality that's created by these issues. So what worked? So social hubs, small group sessions worked really well. Being able to talk one-on-one with people, question and answer sessions. There are a lot of questions about some of these WhatsApp forwards. Last week someone asked if a specific herb was able to completely cure hypertension, so they didn't have to take their medication. Another person asked whether walking was actually more dangerous for them because they were feeling knee pain. Things like this we're really able to address with question and answer sessions and using non-medical jargon. Faisal's spoken a lot about language and how important it is. And one of the comments someone made was the doctor was able to speak to me in my own language. I was able to speak to some of the people in a Ghanaian language called Tree, and just that little element of familiarity meant that people felt more comfortable to ask questions that they'd been worried about. Comments like, I didn't realize exercise was so important. I love the health walks. I didn't feel embarrassed to ask questions. People that were previously afraid of the gym, but now finding the sessions fun. And actually finding that some people had a high blood pressure that needed to visit their GPs. These free sessions allow people to expand their knowledge, but also to address some of their own health concerns as well. Outdoor gym sessions worked really well, and the health walks are still ongoing. That's it from me. I just wanted to say that again, you can contact myself, Faisal, or Lacey if you do feel like you want to collaborate with any of these type of projects.